This is Dr. Chris Robertson providing an overview of tuberculosis. TB is an infectious disease caused by Mycobacterium tuberculosis. It's transmitted by inhalation of airborne bacilla. Keep in mind, transmission requires close, prolonged contact, and transmission occurs when the person that is infected with tuberculosis coughs, sneezes, shouts, or sings. When that occurs, you have droplets that are inhaled and reach the alveoli of the lungs via the nasal passages, the respiratory tract, into the bronchi and begin multiplying. So anytime someone is exposed to tuberculosis, that is kind of the first step. There's an exposure. Following the exposure, the person will either get infected or not get infected. For persons that end up getting infected, they will go into one of two states. They will have what is called latent infection, or they will progress to have what is called active disease. Persons with latent infection, they're asymptomatic. They are not infectious. Whereas persons who are active, they have active disease and bacteria that is growing and multiplying and causing symptoms. Persons with latent tuberculosis infection, they are offered treatment. It is optional. And so you have some persons with LTBI that will be treated and some persons who will not. In persons with LTBI that are not treated, about 10% of those persons will progress to active tuberculosis disease. So latent tuberculosis infection, the infection is present. However, if you want to think of it as being in a dormant state, if they are not treated with what is called preventive therapy, at some point in time, that dormant infection can wake up and develop into active disease. And obviously, persons with active disease, be it because they were exposed and infected and developed active disease, or because they were exposed, had latent infection, were not treated, and then progressed to active disease, that then contributes to additional exposure. It's very important that you understand risk factors related to tuberculosis with regards to homeless individuals, close quarters, like persons in correctional facilities, nursing homes, close contact with infected individuals, persons from areas with high incidence of active tuberculosis, healthcare workers, medically underserved, and substance abusers. Development of disease once infected, particularly those who would develop into active disease, or perhaps those with latent infection that would later be untreated and develop into active disease. You worry about persons that are immunocompromised, have some type of chronic illness, children less than 5, persons who may be malnourished on systemic corticosteroids, alcohol abuse, cigarette smokers, and I think I already mentioned malnutrition. When it comes to the guideline that we use, or that you would reference with anything related to tuberculosis, is typically collaboratively between the CDC and the American Thoracic Society and the Infectious Disease Society of America. This collaborative guideline and information can be found on the CDC website. To recap, latent TB infection, person has been exposed within 2 weeks. Their immune system basically surrounds the bacilla and contains it. So there is a barrier shell called a granuloma that keeps the bacilla contained and under control. However, an active infection, say the immune system cannot keep the bacilla contained and under control, they begin to multiply rapidly and they progress to tuberculosis disease. And obviously, It can be in other areas besides the lung, can be in the kidneys, brain, or bone. It's important to distinguish the difference between latent infection versus active disease. And those differences are listed here. Persons with latent infection have a small amount of bacteria in their body that is inactive, versus someone with active disease, that bacteria is actively multiplying. Persons with latent infection cannot spread tuberculosis to others. They are not contagious, whereas those with active disease are. Persons with latent infection do not feel sick. They're asymptomatic. They will have a positive TB skin test or a TB blood test reaction indicating that they have tuberculosis infection. Their radiograph is typically normal. Their chest x-ray, sputum, smears, and culture are negative. Remember, because the bacilla is contained and is under control. These persons, even though the infection is dormant, it is inactive, they still should consider treatment so that they are not at risk for progressing to active disease. Because they are not contagious, there's no need for respiratory isolation, and they are not considered a tuberculosis case. Persons with tuberculosis disease obviously are contagious. They are coughing the bacilla into the air, and they may spread tuberculosis to others. They are symptomatic. They too will have a positive TB skin test as well as a TB blood test indicating TB infection. Their chest x-rays are typically abnormal. Their sputum, smears, and cultures may be positive. They need treatment and are required by law to take treatment. They may require respiratory isolation if they are determined to be contagious, and they are considered a tuberculosis case. When you look at the symptoms as well as the physical exam findings, persons with tuberculosis will commonly report with fever, chills. You'll have the increased heart rate, likely due to the fever, unexplained weight loss, night sweats. And some of the symptoms, if you're dealing with the case of extrapulmonary tuberculosis, will be related to the site of the TB. From an objective perspective, you're looking at rhonchi, wheals, wheezing, dullness of percussion, asymmetrical expansion, as well as, again, depending if it's extrapulmonary, the symptoms are going to coincide with where the tuberculosis actually is. It's important that you're aware of screening recommendations and who should be screened for tuberculosis. That is listed here. This is taken from your text. With regards to how to interpret a skin test, the tuberculin skin test itself, the immune cells respond, causing a will to rise. The test must be read within 48 to 72 hours, not after 72 hours and not before 48 hours. And this is a type 4 reaction. It is a delayed type cellular hypersensitivity. It's important to also know how to interpret the reading. You are measuring the area of induration and not necessarily the area of erythema or redness. And it is measured in millimeters. And so you need to know how to interpret TB skin testing and understand what is positive depends on different factors. So typically greater than 15 millimeters is considered positive. However, there are situations in which a 5 or 10 millimeter reading is considered a positive reading, and those are listed here in this table from your text. With respect to those positive readings, you also want to keep in mind some of the factors that may contribute to a decreased response to tuberculosis skin testing. Again, these are considerations that you should be aware of. Other types of diagnostics that you may see used more commonly now are the IGRA testing, which you have the quantiferon TB Gold, or the T-spot test. Both of these are going to detect infection by measuring an immune response in the blood. Now, it may be used in place of, but not in addition to, the tuberculin skin test. You don't need both. You typically do one or the other. Persons that you want to use the IGRA testing for are persons who may not return for tuberculin skin testing, or persons who previously received the BCG vaccination. When you look at a comparison of the TST and the IGRA options that are available, keep in mind again the number of visits that are required, the time frame to get the blood to the lab, and also to get the results, the cost, and again the cross reaction with persons who've had BCG vaccine. Obviously, with the blood testing, that is not going to be a concern, whereas persons who've had a tuberculin skin test, they are always going to have persons with LTBI are always going to have a positive tuberculin skin test, even though the disease is latent or inactive. So this is a table that just shows some of the preferred testing, and you can see overwhelmingly IGRA is preferred, recommended. When it comes to diagnostics, actually diagnosing someone with tuberculosis, you're going to need a chest x-ray. The chest x-ray, however, is not confirmative. Typically a PA view is standard. You may see a PA and lateral view. It's not uncommon, but the PA is standard. What is going to confirm if someone has active tuberculosis is going to be sputum evaluation. So they're going to be looking at an AFB smear of the sputum to see if there are bacilli present. NAA testing is going to actually look for the genetic TB material to confirm that it's there. You also have cultures that are done. Culture is currently the gold standard for diagnosis. And you will also see some drug susceptibility testing that is done on sputum to make sure that the medications that are typically prescribed are appropriate. It does take some time for sputum to culture, typically a couple of weeks, to confirm, and in that time with persons where the chest x-ray was abnormal and there was a positive TB skin test, the person has already started treatment. Susceptibility testing is also important when you take into consideration drug resistant or multi-drug resistant organisms. So when it comes to treatment options, let's see if I wanted to go back and say anything here. Okay, I believe that's it. I just want, with tuberculosis diagnosis, keep in mind that depending on the type of testing you're doing, how your patients are presenting, what you're testing for, if you have someone who comes in for an annual TB skin test for their employer and it is positive, say it's 17 millimeters, and they have to have a chest x-ray, and that chest x-ray is negative, you're indicating that they do not appear to have any active pulmonary disease, and likely they have latent tuberculosis infection. So again, with that chest x-ray, or even with the sputum, if you did have someone who came in and had symptoms that were concerning and had a history of a positive TB skin test, so you knew that they had latent tuberculosis infection, they declined the preventive treatment, and now let's say they're recently diagnosed within the last year with, let's say, HIV or diabetes, and now they're coming in symptomatic and they have a fever, chills, and they're coughing up blood. You are going to definitely have tuberculosis as one of your differentials given their history, given the context of their history. And so in that instance, you don't know, does this person still have LTBI? And maybe they're dealing with community-acquired pneumonia, or does this person now have active tuberculosis disease? So your chest x-ray is going to give you indication one way or the other. However, your sputum evaluation will also. The AFB smear is something that is typically done and can result more quickly, and you know if they are coughing the mycobacterium into the air. They're able to measure that. So with regards to treatment, the most that you probably need to be familiar with as primary care provider are first line medications, and more so from the standpoint of, as you encounter these patients that may be on medication, that you at least understand that they're treating tuberculosis, be it latent infection or active disease, but what some of the adverse reactions are and what are some prescribing considerations. Isoniazid, I may talk about it in a little bit, but you worry about peripheral neuropathy. So these patients tend to be given B6 to offset that. There's some considerations with rifampin, pyrazinamide, and ethambutol is something that can affect vision, and so that's something else that you want to be aware of and know. And most of these medications, there's always concern for altered liver function. And so monitoring hepatic function while they're on these medications is something that happens, and that typically occurs by the person who is prescribing the medication. These patients are typically treated by either pulmonologists or, more commonly, infectious disease. So they're responsible for monitoring. However, as your patient in primary care, they may be on other medications that you may need to see if you need to change or adjust dosages given the TB regimen that they're taking. So when you look at LTBI, I want you to first understand that treatment is available to them through the health department at no cost. Historically, you do have some patients that will be treated through their primary care infection for LTBI infection. That is okay and appropriate. But again, you need to know when treatment is indicated. So if you have persons that are high or low risk, they have a positive TB skin test or a positive IgRA, treatment is indicated. Also, when you have close contacts to confirm tuberculosis cases, and even if their TB skin test is negative or their IgRA is negative because they've had the close contact, you still want to treat them anyway. These regimens consist of INH or isoniazid for 6 to 9 months. That's most common. There are shorter regimens which have a combo with the isoniazid and rifampin, or there's rifampin for 4 months, but there's obviously some concern with renal and kidney function with the rifampin. Everybody doesn't do well with rifampin. Patients on LTBI preventive treatment, from a monitoring standpoint, they're typically monitored monthly. Health department offers this at no cost. However, if you're treating a patient for this, you would want to see them monthly to monitor them for any side or adverse effects, to make sure they're taking the medication. Again, with the isoniazid, peripheral neuropathy is not uncommon. B6 is given to counteract. With the isoniazid and rifampin, you're concerned about elevated LFTs. You would check them at baseline, but also check if there were any symptoms present. So if the patient had brown discolored urine, or if there was some right upper quadrant abdominal pain. Rifampin, you have to worry about hyperuricemia as well as hematuria. And in persons with LTBI, you want to make sure that HIV testing occurs, because you want to identify it and know what you're working with, because that would increase their risk of developing active disease. When it comes to persons with active tuberculosis disease, these are persons where the tuberculosis is multiplying, growing, and causing symptoms. If there's any clinical suspicion, if a patient comes in with history of a positive TB skin test and their fever, chills, weight loss in the last month, and they're coughing up blood, you definitely want to act accordingly and treat immediately. Put them on respiratory and droplet precautions. Again, these regimens are typically determined by the specialist, and there are regimens where persons typically are treated for about 6 months. It's not necessarily that you know what these are specifically. They're listed here so that you can see and get an idea for what those treatment options are, recognizing that there is an initial phase and there is a continuation phase. With regards to monitoring and follow-up, again, adherence is extremely important. In this regard, they are required by law to take their medication, and that is called DOT, or directly observed therapy. They will either come to the health department to get medication and take it, or they may have someone from the health department bring the medicine to them in their home to actually watch them take their medication. Again, same thing, INH, peripheral neuropathy. INH and rifampin, you're worried about the elevated LFTs, checking at baseline, and again, if the patient is symptomatic. Rifampin, hyperuricemia and hematuria with ethambutol, the visual acuity and color vision. Patients with active TB disease, they have interval chest x-rays. Do not recall specifically if it is every month or so. However, that is determined by the specialist how often those chest x-rays occur. They are tested for HIV because, again, this may impact their treatment regimen and course of therapy. And they have sputum cultures until those cultures are negative. And you typically expect conversion within 2 to 3 months. And that is the culture, not the smear. The smear gives you an idea about how infectious they are. Once patients start treatment, they typically do not have the bacilla in the smear. Typically, if the regimen, or if the bacteria is susceptible to their regimen, typically within 2 to 3 weeks. Their AFB smears will convert and they're negative. Cultures, again, may take a little bit longer. So someone may be on treatment for 2 to 3 months before they actually no longer culture TB in their sputum. And if there's no conversion, that's when you start suspecting drug resistance, or the person treating them would suspect drug resistance. Again, regimen compliance is a big issue with tuberculosis, and that is whether they have LTBI or active disease. Directly observed therapy is required with active disease. Those persons are typically quarantined for the time that they are infectious, which again lasts a couple of weeks. Respiratory hygiene is important, and these are specific to persons with active disease. It's important for them in the home to make sure that they cover their mouth when they cough, that they discard any used tissues. They may have a fan in the window to blow out air in the room, and also to identify contacts and make sure that they are tested. With regards to what you would be doing as a primary care, when you suspect that someone has tuberculosis, you would be doing the appropriate testing, be it the TB skin test or the IGRA. You would be sending them for a chest x-ray. with the mask on, and also possibly getting a sputum sample. You would have them go home and quarantine themselves and notify the health department immediately, and that is the respiratory isolation component when I mention quarantine. So those are the things that you would do as a primary care provider. This is here just again so that you recognize when you suspect active disease, you're going to refer them to the health department. That's typically at the point of the abnormal chest x-ray. So the health department will then take over with regards to evaluation and management. And that concludes the segment on tuberculosis.